Well, good morning, everyone. I really appreciate you spending half of your Saturday here. I know it's a big deal. Everybody has a busy work week and family and everything, and I'm just honored and privileged to be here with you. Okay, I have about an hour and 5 minutes. This is about the 8th time that I presented this lecture on prognosis. And I came to the realization after presenting it up in Portland, Oregon, that I needed to change the whole thing. So if any of you have heard this lecture before, it's totally revamped. So the title is Prognosis. Now, I mean, why would you get up on a Saturday morning to listen to a lecture on prognosis? How incredibly boring could that be? Okay, I'm going to try to make a story of this and really bring it to life. And the way I'm making the story of this is I was fortunate enough to be a director for the American Board of Periodontology. And when you do something like that, they have a written and they have an oral exam. And in the oral exam, I'm going to skip forward here for just a second. In the oral exam, we show a quadrant of a patient's mouth. And we ask the candidate periodontist who wants to become board certified a line of questions in 6 categories. We ask them, when they look at the clinical slides, they look at the charting and they look at the radiograph, we ask them to make a diagnosis. And then once they make the diagnosis, what are the etiologic factors that have caused this particular disease? We're going to leave this out for just a second right here, which is where the prognosis is going to fit. And then we ask them, what are your treatment options? Then what is your definitive treatment plan? And then once you did the treatment, how do you evaluate and maintain this? So starting way back in 2007, I'm going to Dallas, I'm giving these exams. We would give, at that time, like 28 exams in 1 week, which would kill us. And then we would go home. And I thought, you know, that's an interesting format. It's a really interesting format for an educational body to test a candidate for board certification. And I thought to myself, well, how did that come about? What's the fundamental basis for asking in those 6 categories? And the more I thought about it is, you know, that's the real world of periodontics, whether it's in a perio office or whether it's in a restorative office. So when you have a new patient that comes into your office, whether the periodontist or the restorative dentist, you're certainly looking for oral pathology and all of that stuff, and you're looking for whatever restorative work needs to be done and caries and so forth. But I mean, you have a real profound job of identifying what the disease is. If you're wrong on making your diagnosis, you can be treating forever and the case isn't going to go right. If you can't identify the etiology problems, okay, now you have to have several treatment options available in your armamentarium in order to treat a patient, okay? Quite often you don't just stop with scaling and root planing. If there's residual deep pockets, you really should do something else. Now, do you do open flap debridement, modified Widman periosurgery, split thickness flap, full thickness flap, osseous recontouring, GTR, bone graft, membranes, biologics, or remove the tooth and place an implant? And then you have to come up with the right option, and then you have to evaluate it and put it on a maintenance. And I'll show you later on, if you don't have a proper maintenance protocol for your practice, you can do all the treatment in the world and you're only going to be about half successful. Okay, now the area that really interested me, and I'm like super passionate about this, is called prognosis. Prognosis. So that's what we're going to talk about today, prognosis. Let me back up just for a second here. And I'm really very lucky to have such a supportive staff. There's one person that's not on here. She just didn't make the picture at that particular time, Senovita Lopez. She's former full-time professor at USC. This is Stacy. She's one of our assistants, along with Lupe. Lupe is my full-time surgical assistant. This is Crystal, a hygienist, SC trained. Diane, our office manager. Martha, our PR person. Chris, our hygiene coordinator. And Jessica Luong, also SC trained. So I'm really, I'm here because they let me to be here, and they allow me to have a really fun time in my office. Okay, so we're getting back to this. What does prognosis mean? Foreknowledge, okay, from the Greek, foreknowing, a forecast of the probable course of a disease and the possibility of recovery. Now, what makes this really interesting is the fact the probable course of a disease. Now, perio is, in my opinion, after being in private practice for almost 38 years, a very difficult to understand disease. It's kind of like a bunch of cats. You don't know where those cats are running around to. And you always have to keep your eyes on those cats because the disease is going to change somehow. So, you know, going back to this American board, so we'd have the candidate in the jail cell while we were questioning him, and we would ask him, you know, what do you believe is the prognosis for these teeth? And what's the fundamental basis for establishing your prognosis? What's it based on? And they would go, well, it's teeth have a fair prognosis, or I'd take those teeth out and I'd put an implant in. Okay, and I would ask, why? What's your fundamental basis? And they might give me one reference. And I would say, well, why did you give me that reference? And they would say, well, that was the reference we were taught in our residency program. And I thought to myself, you know what? I was an examiner, I was a director, I didn't even know any more than that. So I took it upon myself to go back into literature, and I wanted to find the best articles to define what exactly prognosis is in the modern times and bring it up to today. So that's what I did. So I took, this is years worth of work showing the articles and trying to make sense of them. Some of these articles I've read 20 times, and I'm finally starting to make sense of it, trying to put it together and make it a story that's simple for you to use. Now, how many times, if you were a hygienist or a restorative dentist, you call two different periodontists because the patient went to two places, and you talk to the periodontist and you ask him, you know, what do you think about these teeth? In other words, what's the prognosis? And he goes, I think I can save them. And then the patient ended up going somewhere else, and so you track the patient down. You know, you have your office manager call their cell, their home, their work, their mother, their brother, text them, email them, you know. Well, where'd you go? Well, I went over there. So you call up and you ask the periodontist, what do you think? He said, well, I already took the teeth out and put implants in. Hey, you know, we do implants every day in our office too, but I have a different philosophy. I put the implants in when I don't think I can retain the teeth. Now, there's 2 lectures here. There's this lecture that I'm showing you on prognosis, but I'm going to show you my cases. I'm not showing you somebody else's cases. I'm going to show you some short-term cases and some long-term cases, so you can get a flavor of really what a periodontist that practices in one office does for 38 years. Okay, now, you know this. You know, we were told for a period of time that, well, maybe there isn't as much periodontal disease out there. Okay, well, we're not busy. Okay, because the periodontal disease went away. Okay, well, the periodontal disease hasn't gone away. I don't want to read the slides. You guys can read the slides. Look at how many people, almost half the United States, has some form or another of periodontitis. I think if I was a general practitioner, I'd send all my restorative to the other general practitioners, and I'd sit there doing perio, because, I mean, there's just such a huge amount of perio to treat. It's just amazing. And then this is an interesting number. We're going to look at this. This is from a new study. About 8.5% develop severe periodontitis. You're going to see over the modern history of these articles how true that percentage is. Okay, so without treatment, periodontal disease gets worse. We know that. Okay? Now this is when you get the DVD, or if you want to take a note, this study comes up quite often, this ECK study. It's actually out of the Jenko group from Buffalo in 2010. Prevalence of periodontitis in adults in the US. One thing that Arta didn't mention to you is kind of my training. I went to dental school at the State University in New York at Buffalo, and my mentors were Ciancio, Nissengard, and Jenko. So I was actually, for all the dental assistants in the room, I was a dental assistant while I was in dental school, and that's really what piqued my interest to go into perio. But I mean, there's really a high prevalence of periodontitis, so there's plenty of work to do. The progressiveness of periodontal disease is determined by the risk level. I have one son, he's 26, his name is Michael, and I always tell him, you know, limit your risk, watch yourself, just be careful, don't put yourself at risk, okay? He calls me last week, he says, oh Dad, I'm going kayaking with Kirsten. Kirsten's his girlfriend. I says, be careful. He says, I knew you were going to say that. So I said, Michael, just be careful. And I didn't tell him I was going to worry about him all day. So about 4 hours later, he calls me, he goes, Dad, guess what happened? I thought, oh, you knocked your teeth out, you know? I'll check my son's dental insurance and see if I can, you know. So what happens is they were on the American River up there, you know, by Egypt. You know where Egypt is. And at the end of it, there's all these rapids, and they both tipped over and got in the rocks and got cut up and everything. He said, but we're okay, Dad, we had a great time. I says, oh, thank God. Okay, so I'm sure you read the rest of that. We have to talk about fundamentals here before we get into some of these other things. The traditional list of clinical factors used in assigning prognosis. You were taught this in hygiene school, dental school, residency programs, okay, because each tooth has to have a prognosis. And actually, the most diseased part of a tooth should have its own prognosis. So you're looking at horizontal or vertical bone loss, the percent of bone loss, the deepest probing, the deepest furcation, the mobility. Now I want to stress to the restorative folks in this room, When I go into your offices and I look at your charting, or if you mail me the charting as I steal you refer your patient to me, sorry about that, I don't often see mobility on there. Now, when I do my charting in my office after doing the cancer screening, the first thing we do is we check mobility. I think that is a huge determinant of prognosis. And then other things like crown to root ratio, root form. You know, sometimes you see a molar like this that has these short little roots, and you know that's mobile, and then it's going to have a furcation involvement and so forth. So you understand that. Okay, this is cool here. Prognostic factor categories. Patient controlled. This is where all of us need to be leaders and managers of our patients. You know, there's all this talk about leadership and management and business skills and all of that, but when it comes right down to it, whoever you are delivering the care, you have to be a leader and you have to instill change into your patient. You're going to see a couple of our cases and see how fundamentally strong we are on oral hygiene, and we use disclosing solution. I started using disclosing solution when I started in practice on September 6, 1978, and we still use it. The only time we don't use it, the red liquid, is when patients just say, no, I don't want to do that. And we go, okay, fine, okay. But I mean, that's really fundamentally, how many people use disclosing solution now? As a matter of fact, I think I have an extra bottle if somebody answers a question right in my pocket here. It's going on my shirt. Okay, and then we try to talk to patients about compliance, wearing night guards. You know, how many patients do you make a night guard for, and you write in the chart you made a night guard for them, and then you ask them, you wear that? No, okay. But I mean, you really need to work with those are patient-controlled issues, okay? Now you look at the other side of the equation, prognostic factor categories impacted by periodontal treatment, like your probing depth, mobility, furcation involvement, trauma from occlusion, and so forth. Now, I know a lot of people are fixated on probing depth. I look more at the mobility and how much furcation involvement there is. Because it's molars that are usually lost before single-rooted teeth, right? And upper first premolars. Prognostic factors associated with systemic disease. This is where your real big three risk factors come in. Diabetes, immunologic disorders, but the big three would be the DM2. If you were in San Antonio, one of my colleagues is a fellow named Brian Mealy. He's going to speak for CSP up in San Francisco. I mean, there's an epidemic of DM2. And I mean, how critical is that? How much does that really affect perio? I mean, big time. We ask patients to bring their glucometer to their appointments. They look at us like, oh, you're not a real doctor. Well, you know what? I'm kind of a real doctor. You know, and give me something, you know. I mean, my name's on the door. It has DD something on it. Bring your glucometer. Okay. I mean, you know, we saved a lot of days from going bad by having people bring glucometers in. And we're worried about them being hypo rather than hyper, because the diabetologist wants the fasting blood glucose down around 100, and sometimes if they're late for their appointment in the morning and they're coming in, did you eat breakfast? No, you know, and they're just about ready to go out. So, okay. And what's uncontrollable? I mean, you can't change the root form unless you put in a root form implant, okay? The crown to root ratio, the tooth type. If it's a molar, you got to deal with the molar. the age of the patient, and genetics. And we're going to wrap this up with talking about genetics here. And I think it's going to be really interesting to you. Okay, so let's talk about the first case here. This is a simple case. So the restorative dentist is in the middle of doing a crown prep one day, calls me up, says, Tom, he says, I need you to do some crown lengthening. Could you see the patient? I mean, a periodontist doesn't say no, because you don't know when the next referral is going to come, you know? So I said, yeah, so I'm happy to. And I look at the schedule and it's jammed. So this is serious, okay? I'm not kidding. So he says, can I send the patient over now? So I said, oh, sure. I says, we'll be happy to see your patient now. It's like, where am I going to seat this patient, you know? Outside, yeah. No, inside. The insurance doesn't cover it outside. Okay, now this is a simple situation here, but what's a prognosis? When you look at this, other than the distal of this first molar, number 30, you'd have to call that between mild and moderate periodontitis based on the Academy's definition. But the rest of the quadrant doesn't have periodontitis. Long roots, okay, good dense bone. So I'd say periodontally the prognosis is good. So I made a perio prognosis. So after we made the radiograph of this, I called the restorative dentist back. I says, what do you think the endo prognosis says? And I says, well, I don't think it's properly filled, but I don't see a lesion. I said, do we send for endo? He says, no. So he made the endo prognosis as favorable. And I asked him, can you restore this when I'm finished? And he says, well, it depends. If you screw it up, no, you know. So the patient's in the chair, you know, seriously. So the patient looks at me. And I says, well, you need crown lengthening. He says, well, that's what the doctor said, you know, so and I already knew that. So can you do it? And we said, yes. So we did it right then and there, and we took the photos on the fly, and we did the case. Okay, so we took that beautifully formed provisional off, and we looked at this beautifully formed tooth, and you could see on the distal that's where the decay is. Now there's intangibles with everything, okay? There's deep vestibule on the buccal. There's plenty of attached gingiva here, so that adds to the favorable of the prognosis. But we did an inverse bevel incision here, and then reflected the flaps. And what's interesting here, there's thick buccal bone over here and thick lingual bone. So you can't really do this with a laser because you have to establish what's called a biologic width. So you need flap surgery here. You need some osseous. It's not just, you know, tickle this here with something and then you're ready to go. So here it is with a little bit of osseous, and there's obviously some bleeding. Here it is sutured, and you know, I'm of the old school and I use 4/0 silk sutures. The reason I do that is I can see where they are because I'm half blind. No, we use those because we know when those things are going to come out, okay? So we do the suture removal in about 2 weeks. And I don't think it adversely affects the healing because I'll show you what it looks like after it's healed. So here it is, you know. I mean, we really strive for good oral hygiene. And we use a periodontal dressing, which I'm not sure how many people use, but it works in my hands. And then here it is restored. And, you know, he's on his way. We don't need to see that patient again, you know. But we try to trap them into a 3-month recall in our office and never go back to the general dentist. Okay, all right. Now, I think I saw this person in Beverly Hills last week, and he had a facelift, so he's doing better. Let's get into these studies now. Okay, the traditional periodontal prognostication systems are based on mortality, tooth loss. And I'll show you, in the amount of time I have, how this has gone full circle in our specialty. Okay. I remember as a very young periodontist, I was at the USC Hygiene Symposium. I had just moved here from my training at Indiana University, and Dr. Hirschfeld spoke. Now, I tried for a month to try to get a picture of, Dr. Hirschfeld passed away, but this was an early picture, and I really went to extremes to get a picture of Dr. Leonard Hirschfeld. I mean, he was like a god in perio. Now, what's really interesting, these studies were done in private practice. They can't be done in a university because most of the university patients kind of come and go. So these guys aren't getting paid to do this stuff. Okay? They're doing it because they really want to do it. So what they did is they looked at 600 maintenance patients, most that had advanced perio disease, most who have been in a maintenance program for an average of 22 years. They wanted to see what happened to these teeth and the patients. So they had no way of really categorizing it, so they came up with favorable and questionable. Makes sense. Wanted to see what happened to the teeth, and they based their opinion on bone loss, pockets, furcations, and mobility, which makes sense, right? Okay. They didn't look at all 600 at the same time. They did like groupings of it. You got to read the paper. Maybe you guys can read it in one time and get it, but I don't get things the first time around. What they found is instead of just looking just at teeth, they found early on that there were well-maintained patients, downhill patients, and extreme downhill patients. The well-maintained lost like 0 to 3 teeth over 22 years. The downhill lost 4 to 9, and the extreme downhill lost a bunch. And patients who lost more teeth were less predictable in this system. Their system of favorable and questionable. Okay, 83% of those patients in their practice were well maintained. And it said in the paper that if pockets were over a certain point, and I think 5, they did surgery on it. A surgery that was in vogue at the time. Now Leonard Hirschfeld was the son of Isidore, and Isidore the dad had to practice before him. Okay, I mean that's like really history. If you were back in New York, that's a big deal. So this practice had been in existence for a long, long time. Okay, so they did surgery on these patients. I guess they didn't send them back, so but they were maintained in the perio office. Not to say, I mean, I don't want to, I mean, I'm like trying to be funny here, but really, I mean, I'm very blessed to work with a great group of referring people, and I think collaboration is really the key of all of this. And I'm one of these guys that calls, talks to hygienists, talks to the restorative dentist, and we establish a basis for who's going to see these patients afterwards. Okay? We have a lot of people that alternate. We have people that we send back, and we ask them, okay, please come once a year, and I'll do a new exam. I do a new exam, and I either find a problem or I don't, and we send them back, and it's great. I mean, because the reality of it is, they don't all have to be seen in a perio office. It's not. It's having courses like this where you have dialogue, where you learn stuff and you get along, okay? I think hopefully I made that point. The study population, you had downhill and extreme downhill. So that totaled up to about 16%. Remember, the new work by the Jenko group had about 8.3%. Okay, but you can see there's a certain segment of the population that's going to have advanced disease. Okay, they didn't look at systemic factors. They didn't talk about different type of plaque accumulation because that was just coming into vogue back there. Okay, I got like stuck on these numbers here for years. We don't need to get stuck on that, but the take home on this is if it's a well-maintained patient, after 22 years, a well-maintained patient lost an average of 0.68 of a tooth. It's pretty amazing, huh? A downhill lost 5.7 and an extreme downhill lost a lot. Probably in today's terms, that would be called the disease aggressive periodontitis. Aggressive periodontitis. Okay, now this comes right out of the article, and I really want to share this with you. Look how symmetrical this is. So these 1 to 8, these are the teeth in the maxillary arch going up, and 1 to 8 is in the mandibular, and here's upper right, lower right. And look at the teeth that were lost here, the molars. And as you get to the single-rooted teeth, how many fewer teeth were lost. And you know what? I wouldn't want you to do this, but you could almost do half of a perio exam and make an assumption that you have the same similar issues on the other side. Similar issues. I don't want you ever to, have Delta call me, Dr. Kepic. You gave a lecture and you only said to probe half the mouth, but you can understand that. Okay. So here's Hirschfeld's conclusions, which were pretty amazing for the day. There were definite patterns of tooth loss in periodontal disease. The prognosis of questionable teeth depends on the general trend of the case. And I'm going to let the cat out of the bag and call that the stability of the case, because we're going to show how we're going from tooth mortality to tooth stability to make an informed prognosis. And there's irregularly spaced cycles of cyclically active disease. Now, how many hygienists have been in private practice for a long time, and the patients are with you on a 3-month or 4-month, and then they're doing really well, like 2 and 3 millimeters and a couple 4s and maybe a couple 5s, and then you do your localized scaling and root planing and maybe put in some medication and it gets better. But then there's periods where all of a sudden the bottom starts falling out. You know what? That disease has really changed, and then you really have to go after it full blast. But you don't know when these irregular cycles are going to pop up, whether they're in your mouth or whether they're in your patient's mouth.